Boy, am I excited about today. We get to talk with one of my dear friends and national experts on quality and safety and implementation, and it's going to be what a thrill. Hi, I'm Bruce Spurlock. I'm a physician and healthcare leader committed to helping decision makers navigate change with clarity. On Viral Healthcare, we explore the ideas spreading across the healthcare landscape and how to implement them successfully and effectively. And today we have my friend Helen Macfie. What a dear person. We've been working for over 20 years together, trying to improve the healthcare system. And let me tell you, she's made a huge impact. And you get to learn and listen to her today. And boy, it's going to be really exciting. Let me give you a little bit of background about Helen. She's semi-retired, and that's really a misnomer. She's working full-time on all her activities, but for 20 plus years, she was the transformation leader and just one of the major executives at the Memorial Healthcare System. And she was involved with a bunch of national organizations as well. She did so many implementations, so many executions. She helped that organization really come and be one of the leading ones in California. But now she's spending a lot of her time with the Institute for Healthcare Improvement, and she's on national safety and quality committees, and she's teaching and developing curriculum and mechanisms for the whole country to really improve. And I'm really excited about you learning from Helen. Helen, welcome to our show. And do you want to share anything else with the listeners about your background?
Well, I'm a pharmacist, as you can see, and worked every nook and cranny of healthcare, inpatient, outpatient, ICU, nights, all of it, on my way to becoming my eventual role, which was, I used to describe it as in three parts. So big performance improvement, improving the performance of healthcare for the real people in the real place doing the real thing, so patients, caregivers, physicians, etc. And strategic planning. So that was another third of my job. So I got to support the organizational efforts around, all kinds of strategy. And then finally, the last third was I affectionately called gnarly projects, really complicated execution rollouts, that kind of have to have a thoughtful design and getting them out there. So like COVID command or lean deployment or a clinically integrated network. And then the last thing I'll say is, this sort of semi-retirement, I've coined a new term, or somebody gave it to me. It's called preferment. You get to work on what you prefer to do, like talking to Bruce today and all of you.
Great. That's great. I love it. I'm going to use that word preferment. All right, let's go into that gnarly category. I think that's really good. So on Viral Healthcare, we talk a lot about sort of implementation success or decision-making success. It starts back with like when we're even considering doing one of those things like clinically integrated networks and all the rollouts you talked about. But let's focus on the gnarly implementation. And can you give us, I like to compare and contrast. Can you give us some examples of something that worked really well and then maybe something that was rougher around the edges, it partially was successful, and I'd love to compare and contrast why something was really effective and why things maybe had a more difficult time being implemented in your organization.
Yeah, well, I've certainly got plenty of experience on both sides of that coin, but I think in terms of like an example of something that worked really well, barcoded medication administration. So obviously a big safety concern, also something on a STARS map potentially, and so a big push from IT to get that in and done and kind of check the box. And the way that, I and the team, so there's no I in team, right, but we found our way to successful implementations is really by first making sure you're solving a problem you need solved. So, and I think in the case of BCMA, it's overarching goal is very, very helpful, and it does hardwire and automate some things that are worth automating. So we had gone through that, but this idea of making, basically don't fire before you're aimed and ready, so like basically take the time to step back and create a roadmap. So we were a big lean shop at Memorial Care, and that was another gnarly deployment. And taking the time to really be thoughtful about how are we going to do this? Who are the stakeholders that need to be involved? What's the governance structure? Actually taking the time, we would do sort of strategic process design or system process design, where we take, we kind of gather the group of the folks this is going to touch and basically go and do a whole mapping exercise about what could possibly go wrong here. So basically doing an FMEA, failure mode and effects analysis, before you ever launch anything. And kind of getting what are the big platforms or swim lanes we need to be filling in. So communications with staff, preventing workarounds. How do we think about piloting this, and where do we turn it on first, second, third, as opposed to, is it big bang? We're going to just turn it on and hope. So really being thoughtful up front. And that in that case, I will say I had a great clinical co-team leader, and a lot of, the physicians, of course, were involved, nursing, pharmacy, others, to get everybody at the table and then have a cadence of overseeing it well, communication check-ins, constantly being able to be flexible and evolve the model as we found out more and more. And of course, bringing the vendor into the room, in this case, the EMR vendor, to make sure that we hadn't missed something and we were taking advantage of all the best practice opportunities that would make this a success. And that rollout was wonderful. I mean, it was a joy.
All right, I want to stop you there because people can understand if they've been watching some of our podcasts and some of our previous episodes, you hit on a number of things that we've talked about before. So making sure you've got the right problem and you diagnose the problem and don't really just come with what you think is the problem and you haven't really done deep dive on it. You've done sort of the failure discussion where you anticipate failure, try to mitigate in advance, and then be responsive to it when you can't do all of those things. And then also, understanding the implementation from both the frontline perspective and the strategic perspective. So these are themes that we've been talking about, and now, folks, you can understand why I wanted Helen on our conversation. All right, keep going, Helen. Talk about the things that maybe didn't work so well.
Yeah, well, I think just to add to that little list of what you do need, I think the other thing is not to forget to communicate with other key departments and stakeholders that should be involved. You don't always think about, well, finance is one, right? So you want to make sure that they're on board. Obviously, IT in this case, example, legal. Is another one that sometimes gets overlooked. HR, so there are other kinds of key support disciplines on the team that need to know what's happening with the real people in the real place doing the real thing. So I think an example of one that didn't go so well was, you'll remember, Bruce, at a time, and actually this is still in place, so we found our way through it. Persistence pays off. But this was actually an example of pulling in robots. Basically they're UV light robots. And so at the time it was kind of beta on, kind of coming into the forefront of thinking about infection prevention. And this idea, which conceptually makes a lot of sense, send a robot into a room, have it irradiate the room with this light to basically kill every germ that's in there. Like, who wouldn't want that? So there was a problem we're trying to solve. We're working on reducing infections. We've got this technology. It's pricey. Those robots are, a little bit of money. And there's a opportunity cost in there because you've got to have people running the robots, making sure they go to the right place. So heavy involvement of environmental services. Is that a contract service or your service? So you start getting deeper and deeper into how is this going to be designed? So the infection preventionists thought, this is sliced bread. We're just going to turn this thing on. And over here, you've got all of those things I mentioned earlier that need to be figured out up front. And I will say, in that case, I had to, as an executive, I think our role as executives is to be helpful and barrier removers, specialists, all of that. I wasn't as involved, and we missed a couple steps in what I rattled off earlier. So we didn't have that executive sponsorship kind of directly involved. We made some assumptions about how much EVS resource there really was to run these things. And I think the third big root cause was we hadn't really prioritized where we would pilot first and use them. Like, where's the best, highest need for the problem you're trying to solve? So now think ICU, isolation rooms, OR turnover. You can quickly get into where you would think this would be helpful versus turning it on big bang. So the last thing I'll say is, so it failed initially, and there's this idea of failing forward. It's okay to fail as long as you learn and fail forward. And we immediately kind of did a debrief on what, it sort of worked, but it wasn't perfect. Don't let perfect be the enemy of good enough. However, it had opportunity. So we reconvened a team, we kind of remapped it, and then went kind of back into the steps I mentioned earlier. And it's still in use today. So I'm very pleased with that outcome. And it it's not the only thing you do to reduce infections, but it is a piece of the puzzle. So I think it's been a win-win. And I'll say one thing about persistence pays off. It is okay to fail as long as you fix it. So as an executive, if you let it flounder, it becomes this blame game because somebody paid for it and it's not delivering and this and that. You've got to kind of basically triage these things and get involved where they need your help so that you can get it back to where it really could deliver on the promise it originally said it had. Then the last thing I'll say is I think sometimes there's something about so I worked heavily with finance, and we developed a whole capital approval process, shared capital approval process for strategic planning, finance, quality, all of it. And I think partnering with finance up front to understand how they think, and to understand, all right, so it's not just about the cost of getting the thing. I mentioned opportunity costs. We're taking up staff time and leadership time where it's going to take other monies we haven't yet figured out, IT time, for example. And having criteria that you share that then when thinking about the business case and the rate of return, the depreciation factors, you actually have to become a little more fluent in that to lead these kinds of projects.
So, it's interesting. Amy Edmondson, a researcher at Harvard, has written a book and several books. And the last one she wrote was about sort of understanding the right kind of failure. And you described that well, where failure is part of the journey of learning and how you learn from it, how you execute, how you recover from it is really more descriptive of organizational capacity than actually the failure itself. So you've described that well. The other thing I was really excited, folks, Helen just gave us a preview of a future discussion we're going to have on this podcast, and that's this idea of being a beta tester. And we're going to talk about the early adopter tax. And you just described it really well. You're one of the first people to adopt it. It hadn't really been deployed widely, and therefore some of the mistakes you might have made or some of the things you learned along is something will help the next group that not make some of those same mistakes because you guys were the ones who paid that early adopter tax. And then the final point that I'm going to talk about, you mentioned a magical word in all of that was really great. It's called opportunity cost. And that's something I think so many organizations just overlook. When you start something new, when you do an implementation or a new decision about an idea, you give up something. You may not think you do, but you're either giving up something you're doing now or something you could do. And opportunity cost is a huge thing that we underestimate, we don't explore very well. And I'm really glad you talked about it because it is a real phenomena that many organizations don't do. All right, I want to jump forward to this topic about companies that I've seen, and I don't think you're like this because I think you can understand it, but I see a lot of companies that are called solution first. I'd call them solution first. In other words, they go to a meeting, they see a topic, and they say, oh, we got to do that here. Or a vendor comes in and it looks shiny and splashy, and oh, we got to implement there. How do you avoid being one of those, like a solution presents itself and you're not even sure what the problem it is you're trying to solve or, those kind of things? How do you avoid being that solution first company, Helen?
Yeah, I think you said it really well. There were so many solutions out there. I mean, just think about AI and how many people are trying to sell, my inbox as a chief transformation officer was full every day, except for the work stuff, with people trying to sell us something. And I think that, respectfully said, I think people who create things and innovate, they can be great partners. And we certainly have, I think, made strides forward working with those kinds of companies. However, it is important to remember that the folks that work for them, they believe in that thing 100%. And there potentially then could be biases and blinders. And I can't tell you the number of times people would come to me and this is going to save like world health, world peace, and every pressure ulcer is going to be eliminated. And I'm like, really? Okay, so let's unbundle that. Or they think they know your data and how many of these issues they have because they've mined publicly available data, which is old, of course, usually 2 or 3 years delayed. And they'll go, well, I know that you had this many readmissions or this many infections. It's like, well, actually, fast forward, here's where we are now. And this is actually the problem we're trying to solve. So I'll give you an example. Again, try to say vendor agnostic, but remember the silver-coated catheters?
Oh, yeah.
Yeah. Okay.
Yeah.
So that was a big thing. You're going to get these silver-coated, they're urinary catheters to prevent a UTI, a urinary tract infection. And the way that they work is they're impregnated with silver, and that basically is kind of an in place, in situ way of killing bacteria or reducing the bacterial load if there were any bacteria present, which assumes that we've got our real issue is around insertion practices, or that maybe we're just keeping them in too long, so it's going to help us if we're doing that. And so then you have to kind of think it through and go, well, what's the right solution for that problem? Make sure we're doing correct insertion practices and patient selection. So then when we put it in using our best sterile technique, it's good. And then shortening the number of days that the patient actually needs it to what is actually clinically appropriate, and not leaving them in too long for convenience, or we didn't have a hard stop, or whatever it might be. And instead, this catheter was sort of a Band-Aid in the middle. And they cost a lot of money. And then the other thing is, well, how many UTIs do you actually have in your hospital? So it's thinking that way, I think. And so in that case, we decided not to do it. So sometimes the best thing you can do is decide not to do something if it doesn't pencil out. And I think the other things are, so we would have a prioritization matrix. So let's say it's a capital item, meaning it's going to take capital dollars. So there's operating dollars and capital dollars. This is a fixed budgeted amount over here, and we only have so much of it. It's a precious resource, as are operating dollars, like people and supplies. But the capital dollars, basically, let's make it up, we have $1 million to spend, and operations wants some of that, and quality wants some of that, and facilities maintenance wants some of that, and you have to really prioritize. So having a prioritization matrix, and patient safety should be at the top of that, of course, because that's what we do. That's my bias, but it's not the only thing. And so sometimes it's not even like not now. It may just be actually like, when might we? So, okay, maybe we can't do it this year, but we'll think about it next year. Or don't do it just for PR or the STARS map, but this is actually something that's really going to help us. And then finally, I think avoiding the buzzword trap. When somebody comes to you and overclaims, you need to go check your own data. So reduce admissions, reduce pressure ulcers, reduce injuries, and did you know they cost like $35,000 to $70,000 to treat? It's like, yes, I know, but how many do you really have? And will this fix actually impact that? And then I think finally, just slow down. Don't ever be in a rush. Don't be the shiny toy guy or gal. Just because somebody else has it, I can't tell you how many times I heard that. Oh, well, XYZ health system just got that, so, you need it. It's like, well, their issues might be completely different, and their priorities might be different.
No, that's exactly right. And they may have different deficits, and they may have weaknesses that are different than yours. So the context is completely different. I was at this meeting once, and there was this panel. It was a national meeting put on by CMS. There was a panel up with IT vendors and also different companies, device companies, and they were all waxing, sort of moaning about how slow healthcare was to adopt these things. And I wanted to say, it's because you failed as an industry so many times that they're all scarred from those things. So you overpromise, you try to over deliver, and nothing really happens. So it's not really the healthcare system's fault that they're not responding to you in the positive way you want. So, and I really think you're right about, stepping back and having a really good understanding about, is this really best for us in our current situation, given what we have. All right, so let's talk about when you do actually not have a great implementation. And again, if you haven't lived long enough, you haven't been in healthcare long enough, you haven't experienced it. But if you've been in healthcare leadership or in implementation for more than a year or two, you've got a couple of failures. In fact, I ask people regularly to describe those failures because they're ubiquitous throughout healthcare system. What happens if we don't really acknowledge them? What happens if we just sort of ignore and bury them to the organization, to leadership, what do the front lines think about that over time if we're just not really forthright and authentic about some of those failures that are inevitable in healthcare?
Well, I'll say a couple of things about that. I think first off, things can still fail even if you perfectly implement them, especially if they weren't the right solution for the problem you had to begin with. So going back to that proper selection and thoughtful prioritization. But let's assume that there was just a failure in, like, for example, the one I shared earlier. Failure happens. And I think number one is you got to take responsibility for that. as the executive and help the team get to the right place. I think the consequences of not sticking with it and making it better. I mean, at some point you may have a no-go and go, you know what? We tried it. We've understood it. We know why it didn't work. We're going to abandon. That is okay, as long as you've gone through thoughtfully, you've communicated with all those people I rattled off earlier. I mean, especially finance and legal, about where we are and what's going on. But I think the things that we risk if we take on too many shiny toys or don't plan appropriately, failure to execute, you can probably weather a couple of those. But institutional memory is big. And long. People don't forget. And so there's a couple things. Burnout of the staff and the doctors. So, oh yeah, another initiative of the month, flavor, that was the thing we did last March. And yeah, we'll outlast that. And, this too will go away. We'll be patient. So I think burnout is one. I do think cumulatively, if it's a skill, that is a muscle, like you have to develop this to be able to run these things correctly. And if you don't sort of learn and, make it better next time, then you sort of start to get lack of trust from the CFO, the other executives on the team, finance. We mentioned the opportunity cost, and that is big. There are limited resources, especially now, post-COVID, and the impact that's had on kind of the whole financial underpinnings of healthcare. And we don't have money to waste, and we don't have time to waste. And so going back to proper selection and proper, you can weather a few of those, but I think it's worth doing the things that we talked about earlier. And then again, you don't want to be that person that gets the reputation of the shiny toy syndrome. I went to a meeting once, I won't mention where, but one of these think tank meetings, and there were a lot of executives there, and they're like, well, I'm getting this, and I'm buying this, and I'm, and all it was just a bunch of shiny toy collection. And I'm like, okay, where's the patient and the attention to use of precious resources? They're fixed, and we're getting less and less of these discretionary resources. So it's this responsibility to have a thoughtful process. So again, I think it's okay to say fail forward, but you need to kind of not have that be the only strategy that you're using. And you need to have some good success stories. And then last thing I'll say is, when you do have success stories, make sure everybody understands that they were successful. And so communicating and, sharing what happened, and you delivered on the business case, you delivered on the operational case. So communicating back into the strategic finance framework is super important.
I love it, Helen. So many good things. I mean, you're just full of all these pearls of wisdom. And the one thing I think I'm going to take that was new for me was this idea that it's a muscle that you develop and you build up, trying to execute is what you're describing, and how to make an organization transform, or at least change and adopt new ideas and new innovations. It's not something that you can go to the gym once and you think you've got it done. In fact, if you ever do that, you come back all sore after the first few days of going to the gym for the first time. It's only when you do it repetitively, persistently. That was the other comment you mentioned earlier. So they're really great. I can't believe how rich this conversation has been, and how much I've learned from it. Hopefully the audience has too. Helen, is there any last comment or two that you'd like to share with the audience before we call it a day on this one?
No, I think maybe the one last thing would be, if you're in a position of being able to sort of lead and facilitate, I do think there's something about being open to all these innovations. So being curious is still okay. Like, I wonder what we can do with AI. I wonder what we can do with ambient learning or listening. I wonder, and then it's about, okay, I've got 100 vendors in my email box. How do I think through and starting to just be curious? So it's not about saying no. It's about saying if and how.
Folks, we did not plan this conversation like this, but Helen's basically doing this podcast, writing the book. She's just time after time, just sort of saying, we're not anti-innovation. We love innovation. We think curiosity is key to leadership and trying to figure out what can we do better and how do we do it better. So I love all those examples. Well, I want to thank you, Helen, for a great podcast, great conversation. I learned a lot. I'm sure our audience learned a lot. And these themes that we're talking about are going to be repeated throughout the podcast. If you like this episode and if you like the things we're talking about, join us every Tuesday morning at 9 o'clock Pacific as we describe things in healthcare that helps people make decisions better and implement them more effectively. Next week, we're going to talk about comparing and contrasting several of the well-described interventions in healthcare that have both failed tremendously and been successful tremendously, and how the differences, some of the things that Helen was identifying earlier, we're going to go into more depth next week. And so with that, I'd like to thank you and ask you to join us in the future. And thank you, Helen, for a great conversation.